Hello students, I'm Dr. Manisha Buddhiraja, your Marrow faculty for ENT, and today we will be discussing the ENT questions that we could recall from the recently held NEET 2024. So we had 2 sessions of the exam. So let us first start with the session 1. Now first, seeing the distribution of the questions of ENT, we had 3 questions from the ear, 4 from the nose and 3 from the larynx in the first session. Let us quickly see what these questions were. The first question, which nerve supplies marked parts on the external ear? So yes, the nerve supply of the ear we have seen is a question almost every year in our exams, either directly or as referred otalgia. So this time it was a very direct question. There's the nerve supply of the pinna. Now we already know that the skin that covers the pinna comes from the adjacent areas, and along with that, it also gets the nerve supply from that area, which means that the skin that covers the tragus and the ascending crust of the helix comes from this area, the adjacent area, and the nerve supply will be the same as this area. So what is the nerve supply of this area? Yes, this is the auriculotemporal nerve. Yes, so the nerve supply of the tragus as well as the ascending crest of the helix is the auriculotemporal. Now, the auriculotemporal, along with this part of the pinna, also supplies the anterior wall and the roof of the external auditory canal. And also, it gives a supply to the anterior and the superior parts of the tympanic membrane. Now, otherwise, the greater part of the pinna, yes, is supplied by, as the name, greater auricular. So, the greater auricular, which is a branch of C2, C3, from the angle of jaw, after supplying the angle of jaw, it comes to supply the major part of the lateral as well as the medial surfaces of the pinna. Now, the posterior superior part of the pinna on the medial surface is supplied by the lesser occipital, that is C2. So, from both C2 and C3, in cervical spondylitis, there can be referred pain to the ear. Now, this part, that is the concha of the pinna, this is supplied by the vagus, and there is small contribution from the facial, which supplies the posterior superior part of the external acoustic meatus and the adjacent part of the canal. Now, the vagus also supplies the floor and the posterior wall of the external auditory canal, and also the lower and the posterior part of the tympanic membrane. So, we know that vagus is the main nerve supplier of the larynx, the hypopharynx. So, yes, here is that question asked that in carcinoma of the larynx or carcinoma of the piriform fossa, there is pain in the ear. That is because of which nerve? Yes, vagus. And a repeated question of your exam that while cleaning the ear, patient coughs. This is because of, again, that is because of vagus. Now, last year from this topic, the question was asked in your exam that in a patient of acute tonsillitis, there is pain in the ear because of which nerve? So, yes, any condition of the oropharynx, be it tonsillar infection, or peritonsillar abscess, tonsillar carcinoma, base of tongue carcinoma. So, in all these conditions, the nerve here is the glossopharyngeal. Yes, so there can be pain referred to the ear through the tympanic branch of glossopharyngeal. Yes, what is the name? Jacobson's nerve. And that supplies the middle ear and the medial surface of the tympanic membrane, right? So, this time it was a very direct question. So, here what is A? Yes, this is the auriculotemporal. B is the greater auricular. And C is the vagus along with the facial. So, let us see the choices. The first choice, auriculotemporal. A is auriculotemporal, yes. B is greater auricular. C is facial and vagus. So, we have the answer in the first choice itself. So, the answer is A. So, coming to the next question. Patient with left side vestibular neuritis had positive head impulse test. What does it indicate? So, yes, vestibular neuritis was a very favorite of your INI set, but now it is of NEET also. Yes. So, what exactly do we mean by vestibular neuritis? As the name itis, so it is an acute inflammation of the vestibular nerve. So, what will happen when the vestibular nerve will get inflamed? Yes, it will now not properly conduct the impulses from the vestibular system of that particular side to the brain. So, that will present as a hypoactive labyrinth of that particular side, right? So, this is very important thing for you to know that vestibular neuritis will present as a hypoactive lesion, right? So, now when the labyrinth has become hypoactive, how will this patient present? The patient will present with acute, it is an acute inflammation, so acute sudden onset vertigo. And how will be this vertigo? Will it be episodic? Will it be for few hours or few minutes? How? Yes, see, it is an inflammation, and inflammation will take time to subside. So this vertigo will be a continuous vertigo lasting for 3 to 7 days at least, right? So this patient will present with vertigo for at least 3 to 7 days, and it will be continuous. And what do you think? How will be the hearing of this patient? What is the name of this condition? Vestibular neuritis. So it is specifically the inflammation only of the vestibular nerve. So the hearing will be absolutely normal, right? Hearing will be normal. So this has been a question of your exam. A patient presents with sudden onset vertigo for 3 days and the hearing is absolutely normal. What will you think then? Yes, vestibular neuritis. Now, whenever any patient comes to us with vertigo, what is our approach? We want to find out whether it is a peripheral lesion or it is a central lesion. How do we do that? Yes, that we can do very easily by looking at the nystagmus. So yes, these patients of vestibular neuritis, it is an acute inflammation, sudden onset vertigo, and these patients have spontaneous nystagmus. So the nystagmus of these patients will have all the features of peripheral involvement. Yes, so here we can diagnose by looking at nystagmus. And last year was this question asked that left hypoactive labyrinth, left vestibular neuritis, nystagmus will be towards which side? Yes, so here we know that when complete labyrinth becomes hypoactive, it will be horizontal nystagmus. And always the direction of nystagmus is towards the more active side, right? So if it is a left vestibular neuritis, the left labyrinth has become hypoactive. So which will become the more active? The right will be more active. So nystagmus will be a horizontal nystagmus to the more active side, that is the normal side. So in left vestibular neuritis, it will be towards the right side, more active side. And yes, also can you tell me what's the direction of nystagmus? Is it the fast component or the slow component? Yes, very good. It is a fast component. Again, that is a question of your exams. Also, whenever patient comes to us with vertigo, we need to find out whether it is a peripheral or a central lesion, which we can do by the vestibular function test. So this head impulse test, which has been mentioned in the question here, is one of the vestibular function tests. So what do these vestibular function tests test? As the name, they test whether the vestibular system is functioning normally or not. So what at all is the normal function of the vestibular system? Yes, the vestibular system senses our movement of the head. And in response to that, it immediately sends impulses to our eyes to regulate, to coordinate the movement of the eyes along with the movement of the head, so that no matter how much our head is moving, we can continue to get a clear picture of the desired object that we are viewing, right? For example, right now, I am looking at you. Now, if I want to turn my head to the right and I still want to continue looking at you, will that be possible? Let us see. Yes, that happened. So how did that happen? Yes, the moment I turned my head to the right, my vestibular system of the right side sensed this movement and it immediately sent impulses to my eyes. And what happened? Did my eyes move or it did not move? Yes, it moved, but in the opposite direction and at an equally fast pace as the movement of the head, so that my eyes was still fixed at you and you felt that my eyes did not move at all, right? Yes. So if my vestibular system of the right side is functioning normally, the moment I will suddenly turn my head to the right, my eyes will immediately move at an equally fast pace in the opposite direction as the movement of the head, and my eyes will be fixed at you, right? But if my right vestibular system is not functioning properly, what will happen? The moment I turn my head to the right, the eyes will move in the opposite direction, but they will lag. Yes, so they will be slow. They will not move in the opposite direction at an equally fast pace as the head. So you will see the eye lagging behind, and then just before it comes to the target, that is you, it makes quick, swift movements. These quick movements are what are known as saccades. So it is as if that the eyes are moving slowly. So that is why towards the end, before they reach the target, they start running. Yes, quick movement. these quick movements are saccades, and they will also be like the movement of the eye in the opposite direction, right? So that is what we call as head impulse test. We give swift movements to the head when we are testing the right labyrinth towards the right, when we are testing the left labyrinth to left labyrinth towards the left. And if the vestibular system is not functioning properly, you will see the movement of the eyes in the opposite direction, which will be slow. And towards the end, you will see fast, swift movements in the opposite direction, which are saccade, right? Now, another important thing that we need to know about head impulse test is that it is a very, very important test. That is why it is asked in your exam very commonly. We also know of caloric tests where we are giving cold and hot water. And this is a very, very a disturbing test for the examiner as well as for the patient. You have to use hot water, cold water. The patient will have such severe vertigo, right? So, as compared to that, this head impulse test is a very easy office procedure which you can do in the OPD itself. It can test each labyrinth separately, and not only each labyrinth, it can test each semicircular canal also separately by giving swift movements of the head in the plane of the semicircular canal. So these are the very important things that you need to know in the head impulse test also, right? So coming to this question, patient has left side vestibular neuritis and head impulse test is positive. What does it indicate? So the first choice, on rotating the head to the left, right saccade is seen. It is left vestibular neuritis. So we will test it by rotating the head to the left. The saccade will be, and the movement of the eye will be in the opposite direction. Yes, so right saccade is seen. Yes, that is true. Let us see what the other choices are. Rotating the head to the right. When we are rotating the head to the right, we are testing the right labyrinth. So not this one. Again to the right. No, not this one. Rotating the head to the left. Left saccade is seen. No, the eye movement will be towards the target, which will be opposite direction to the movement of the head, right? So the next question, identify the part of the cochlear implant marked. So we can see an X-ray of a patient who has bilateral cochlear implant, and we can see some parts of the implant, and what has been marked is a wire-like thing, right? Okay, so we know what the parts of the cochlear implant are. Yes, it has an external device. The external device consists of the microphone, which picks up the sound from the surrounding and sends it to the speech processor, which converts this sound into digital signal, and then it sends the digital signal to the transmitter coil. The transmitter coil will then send the digital signal across the skin to the internal device through radio frequency. And what is the internal device? The internal device, which is present just below the skin, this is what is known as the receiver stimulator. This will convert the digital signal to electrical impulses, and that will be sent to the electrodes, right? Now, this receiver stimulator and the transmitter coil are held in one place by magnets. The electrodes are mainly the intracochlear electrodes, which are passed from the mastoid into the middle ear through the facial recess, and then from the middle ear through the round window, they are placed in the scala tympani. Yes, all these have been repeated questions, and we already know that. Now, along with this intracochlear electrode, we have one electrode which stays outside, and yes, that is also electrode. That is also part of electrode, but that is the extracochlear electrode, and that is known as a ground electrode or a reference electrode, right? And it is mainly for power regulation and to regulate the intensity of stimulation. So now let us see what the choices were. So the choices here is ground electrode, internal magnet, receiver stimulator antenna, and transmitter coil. Even if we are not very sure, that we have not heard ground electrode, we know that definitely this is not a magnet. This is a wire. This is something to do with electrode, right? It is not a magnet. Yes, the magnet is here. It is not the receiver stimulator, that is here. It is not the transmitter coil. This is the transmitter coil. These parts we already know. So if you have a question like this where you are not very sure that you have heard this word before, with all the knowledge that you already have about that, you definitely will be able to come to the solution. So keep your mind calm and answer always, right? So yes, what is the answer? This is the ground electrode. So coming to the next question. Sensation will be lost in which area if the marked fissure is compressed? So which is the marked fissure? We can say this is the orbit, and the marked fissure is the superior orbital fissure. Yes, also the student said that it was the skull where superior orbital fissure was marked. So I do not know it was a picture like this or it was a skull given like this and the superior orbital fissure was marked. So where is the superior orbital fissure here? Yes, it is this fissure. So what are the structures that pass through the supraorbital fissure? We have the 3, 4, we have the 6, and along with that, we have the ophthalmic branch of 5th. So we have the first, right? Okay. Now we know that 3, 4, 6 are mainly the motor. This is the sensory. So what is asked in our question is the sensation. So what is asked is the sensory, that is the ophthalmic. So what does ophthalmic enter into the supraorbital fissure as? Yes, it enters as 3 branches into the orbit, the lacrimal, frontal, and nasociliary, right? So, here from the supraorbital fissure, enter the lacrimal, which goes mainly to the lacrimal gland. We have the frontal, which gives us 2 branches, the supraorbital and the supratrochlear, which gives sensation to the forehead. And we have the nasociliary. As the name, it gives the ciliary branches and nasal branches. The nasal branches are the posterior ethmoidal, the anterior ethmoidal, which enter the nose through the same name foramen, and we have the infratrochlear, which gives the sensations, or it is for the sensations of the upper part of the dorsum of the nose. Now, the anterior ethmoidal, it enters the nose, it gives the internal nasal branch, and it gives a branch which is known as external nasal, which comes out at the junction of the nasal bone and the upper lateral cartilage. It comes out from here to supply the lower part of the dorsum of the external nose coming up to the tip of the nose, right? So we now know everything about the sensory supply of the ophthalmic. So let us see what the choices are. Skin over the maxillary sinus and the intraorbital area. The skin over the maxillary sinus and the infraorbital area, this is by the intraorbital nerve which comes out through the infraorbital foramen, and that is a branch of the maxillary, not of the ophthalmic. So no. External auditory canal, no, we just saw it is by the auditotemporal and by the vagus. Lateral wall of nose. What do you think? Lateral wall of nose is mainly supplied by? Yes, it is supplied by the maxillary nerve through the branches of the maxillary nerve, which enter the lateral wall through the sphenopalatine foramen, 1 centimeter behind the middle turbinate. So, that is also not the answer. Skin over the forehead and the tip of nose. Yes, that is exactly where the ophthalmic supply. So, the answer is D. So, the next question. A 45-year-old male presents with nasal obstruction and undergoes a CT scan of the paranasal sinuses. Identify the blocked sinus. So here we have a coronal cut of the CT scan of the nose and paranasal sinuses. So we are seeing the orbit here. Here in the center is the septum, the inferior turbinate. The middle turbinate is not very clear here. Yes, we have the maxillary sinus here and the anterior ethmoids. And we can see that in the maxillary sinus here, we are seeing the discharge here, some connection. So yes, the blocked sinus is which one? We have the maxillary sinus. Now, are we even seeing the frontal sinus in this CT scan? When will we see the frontal sinus here? The frontal sinus, always remember, it will be seen in the most anterior cuts. So when it is an anterior cut, how do we know that this is the anterior cut? Yes, so in the anterior cut, the maxillary sinus will appear very small. Just have a look here. Yes, can you see this? This here is the frontal sinus. How can we make that out? Yes, because the maxillary sinus here is very small. And this thing marked in yellow by the yellow arrow, what is that? Is this the bulla ethmoidalis? No, this is the anterior-most anterior ethmoidal cell, that is the agar nasi. And when we go more posteriorly, this is the more posterior cut, that is the second picture, where we see that the maxillary sinuses are quite huge. And also here now what we are seeing is the bulla ethmoidalis. Now just see that whether it is the anterior cut or little posterior, we will be seeing the orbit, right? Now when we go more posteriorly to see these sphenoid sinuses, the orbit will disappear. Yes, so can you see here? Here the maxillary sinuses are appearing. We are seeing the posterior most part of the maxillary sinuses, so it is appearing oval. And here we are not seeing the orbits anywhere. This is what is the sphenoid sinus. Yes, so in our question, the answer here is the maxillary sinus. Identify the condition based on this image. So what is the image that has been shown here? The first one is an X-ray which is showing that the heart is in the opposite. So this is the dextrocardia. Yes, situs inversus. And the second is the CT of the chest showing the bronchiectasis. And here we are seeing the maxillary sinuses. This is the NCCT of the nose and paranasal sinuses showing that there is sinusitis in the maxillary and in the ethmoid. So this is bronchiectasis, chronic sinusitis, and situs inversus. What is that? Yes, that is Catagna syndrome. What is cystic fibrosis? In cystic fibrosis, will you see bronchiectasis? Yes. Can you see chronic sinusitis? Yes, we will see chronic sinusitis. There can be polyps also in the nose. Yes. But will there be dextrocardia? No. Young's syndrome? Yes. In Young syndrome, we'll see bronchiectasis, chronic sinusitis, but not dextrocardia. That is infertility. And atrophic rhinitis? No dextrocardia, no bronchiectasis, only nasal. So this is Catagna's syndrome. So the next question, a 14-year-old boy presented with nasal obstruction, recurrent episodes of bleeding from the mass. Endoscopic picture is shown below. What is the investigation of choice? So whenever we have a pubertal male with nasal obstruction, recurrent episodes of epistaxis, what comes to our mind? Very good, angiofibroma. And yes, the endoscopic picture is showing the red vascular mass, which almost confirms that yes, this is angiofibroma. But the definitive diagnosis is by the CT scan. Is it NCCT or CECT? Yes. When do we go for contrast? Whenever we know it is a vascular mass. So then it takes up the contrast, enhances on the CT, and then we know that if it is enhancing mass, it is a very vascular mass. So yes, this is CECT, contrast enhanced CT. Right? And here, what is the important finding that we see in CECT? What are we seeing here? So this is the axial cut section where we are seeing the nose here. This is the maxillary sinus. Here, this is the sphenopalatine foramen area where we can see this whitish. Can you see the enhancing mass? Yes, the enhancing mass is present in the sphenopalatine fossa, in the nose, nasopharynx, also laterally into the intratemporal fossa. And this pushing of the posterior wall of the maxillary and anteriorly by the mass in the sphenopalatine fossa is the sign very commonly asked in your exam. Yes, of angiofibroma, the Horman-Miller, also known as the antral sign. A female singer presents with a complaint of not being able to sing in high pitch. On examination, one vocal cord was bowed and at lower level than the other. Which muscle is involved? So here we have a singer who is not able to sing in high pitch. So high pitch is involved. There's a very direct question. Which is the muscle responsible for high pitch, for raising the pitch? Yes, the tensor of the vocal cord, the cricothyroid. Yes, and cricothyroid is the only muscle that is supplied by external laryngeal nerve, right? So previously 2 years, the question was asked that there is injury to external laryngeal nerve. And what will be the presentation in the patient? So the answer there was patient will not be able to raise the pitch. And here they have just reversed the question. Patient is not able to raise the pitch, which is the muscle. So yes, it is cricothyroid. So do we have the cricothyroid? Yes. So the answer is cricothyroid. In given X-ray, which of the following sign is seen? So we can see this is an X-ray AP view. And what we can see here is a round foreign body. Yes, tell me, is this foreign body present in the esophagus or is it present in the larynx? Yes, we know that the longest diameter of the larynx is the AP diameter. So if the foreign body gets stuck in the larynx, it will be like this. On AP view, you will see the rim. Right? On lateral view, you will see the round. Whereas the longest diameter of the esophagus is the horizontal diameter. So the foreign body gets stuck like this, and on the AP view, you see the round thing. So this round thing can be either a coin or, yes, we are seeing that it is not homogeneous. There we can see, yes, two ring-like appearance. Yes, so what is this? This is the typical appearance of a battery a foreign body, which is the battery. And this was the exact picture that was given to you last year and was asked, what is this foreign body? Yes, it was battery. So in battery, the battery has a bileveled appearance, because of which you see two rings. One is this and the outer ring is this, right? So on the AP view, we see a double density like appearance, which is also known as the halo appearance. And on the lateral view, we see a bileveled appearance, and also we see a step off at the edge, right? So yes, this is a foreign body battery, and the sign that we are seeing here is the double ring sign. Double ring sign. Which of the following will be difficult in the given patient? So here we can see an X-ray AP view where we can see that the trachea is grossly deviated, right? So what will be difficult? Let us see the choices. Nasogastric tube. Nasogastric tube is passed to the esophagus. Why should that be difficult? LMA, laryngeal mask airway, is a supraglottic airway device. So yes, it will not be difficult when the trachea is deviated. Tracheostomy. Yes, tracheostomy is, this is here where we do the tracheostomy, so it will be difficult. And the next choice is indirect laryngoscopy. Indirect laryngoscopy is done by passing the indirect laryngoscope into the oropharynx. Why will that be difficult if the trachea is deviated? So, no. So, the answer here is tracheostomy. So, those were the session 1 questions. Let us now do the questions of the session 2. And in the session 2, the distribution was, from the ear, we had 3 questions, nose 3, pharynx 1, and from the larynx, we had 4 questions. Let us see what these questions were. A patient presented with a complaint of hearing loss. The otoscopic finding is shown below. What will be the Rinne's test finding? So here it is a patient who has hearing loss, and what is the otoscopic finding showing? Yes, it is showing a perforation of the tympanic membrane. So perforation of the tympanic membrane is what hearing loss? Conductive hearing loss. And in conductive hearing loss, what is Rinne? Rinne is negative. So let us see the choices. Positive, no, negative. Yes. So the answer is B. A patient presents with pulsatile tinnitus. A red mass was seen behind the tympanic membrane. CT is given below. What is the diagnosis? So whenever we have a patient with pulsatile tinnitus, what comes to our mind? Yes, it is the vascular tumor glomus. And in glomus, will there be a red mass behind the tympanic membrane? Yes, it can be seen. So we know that yes, the answer is glomus. So CT is given below. What is the diagnosis? Let us see the choices. In the choices, we have glomus jugulare, glomus tympanicum, autosclerosis, reparative granuloma. So we definitely know that it is one of the glomus. Okay, so now they want us to diagnose whether it is a glomus jugulare or a glomus tympanicum by looking at the CT, because both will have pulsatile tinnitus. In both, there will be a red mass behind the tympanic membrane. So let us see if we can find out by CT or not. But before that, do we know that glomus tympanicum arises from where? Yes, it arises from the tympanic plexus that is on the promontory. Whereas the glomus jugulare, it arises from the jugular bud that is in the floor of the middle ear. So let us see. This here, what we are seeing is the temporal bone, right? Now here, we can see this here is the mastoid. This is the area of the external auditory canal. This will be the middle ear, and what we are seeing here is the base of skull. So what we are seeing here, this area is the floor of the middle ear. Let me rub this. Yes, so this area is the floor of the middle ear where we can see the bulge of the jugular bulb area, right? And also just behind that, this is the jugular foramen area. If we see in the base of skull in the second picture here, this here is the temporal bone, right? So this here will be the external auditory canal. Here we will have the middle ear. Here we have at the junction of the petrous bone and the occipital bone, we have this foramen. What is this foramen? This is the jugular foramen. Through the jugular foramen, the sigmoid sinus, this here is the sigmoid sinus. So through the jugular foramen, the sigmoid sinus continues as the jugular bulb, which then goes out of the jugular foramen, coming into the floor of the middle ear, which we are seeing in the first picture, right? Okay. So with this basic, now let us come to see the CT scan, right? So now they want us to identify things on the CT scan of the temporal bone also. So yes, we can make out that this is the area of the temporal bone, right? This is the external aortic canal, the air part, and maybe after that we are not able to make out much. But yes, you cannot miss this here. Yes, this is the area of the jugular bulb. On the opposite side, you can see this is the external aortic canal, and here it is smooth here, everything. Yes, here you can see this is the area of the jugular foramen where you're seeing a mass. So yes, this is a glomus jugulare. And believe me, if it is a glomus tympanicum, what you will see is this is the vitreous part that you're seeing. This is the external aortic canal, right? This is the mastoid. Here, this is the area. This will be the area of the jugular foramen area. And here, the tympanic membrane. If it is a glomus tympanicum, you will see the mass as you are seeing in this, just medial to the tympanic membrane on the promontory. And I don't think at all that you will be expected at undergraduate level to diagnose a glomus tympanicum by seeing the the CT scan of the temporal bone. But yes, just the gross anatomy you can make out by the temporal bone CT, because the temporal bone CT is exactly like the skull CT that we see. And here you will be able to make out the mass that is present at the jugular bulb area. So yes, the answer here is the glomus jugulare. Glomus jugulare. So whenever you get a question like that where you feel that no, it is a CT scan, I cannot read it. Yes, do not panic at all. With all the knowledge that you know, try to oppose that question. You will definitely be able to come to the diagnosis. So coming to the next question, a 40-year-old female presents with progressive bilateral conductive hearing loss. The PTA is shown below. Which sign will be seen in this condition? So this is a combination of two questions that we are having here. In the first part, we are supposed to make the diagnosis, and in the second part, we are supposed to say that the diagnosis that we have made, which sign is seen in that condition, right? So whenever we see a middle-aged female with bilateral progressive conductive hearing loss, what comes to our mind? Yes, very good. Otosclerosis, always this should come to your mind. Now, suppose, let me change the question from 40, let me make it a 4-year-old child with bilateral conductive hearing loss. Yes, that's the only history, bilateral conductive hearing loss in 4-year-old child. Now, what will come to your mind? Yes, now serous otitis media. So, history is very, very important. It leads you to the diagnosis. So, yes, we are suspecting otosclerosis. Let us see what the Pureton audiogram is showing. Yes, we can see a AB gap. AB gap means that there is a conductive hearing loss. Also, what we are seeing is that in the bone conduction, there is a dip at 2000 hertz. Yes, that is the Cahart's notch. Right, that's the Cahart's notch. So we know that the diagnosis here is otosclerosis. So now what we have to see is which sign will be seen in otosclerosis. Henneberg sign, what's that? That's positive fistula that is seen in any condition, you can tell me? In superior semicircular canal disease, third window syndrome, it is seen in hypermobile footplate of Stapes, that is in congenital syphilis, in some cases of Meniere's also. So no, not in otosclerosis. Schwartz sign. Yes, what is Schwartz sign? It is the flamingo pink tympanic membrane seen in active otosclerosis because of the increased vascularity of the active focus on the promontory that gives the tympanic membrane a pinkish hue. So that is also known as the flamingo pink appearance, the Schwartz sign. So yes, that will be seen in otosclerosis. What are the other signs here? Hirschfeld-Berger, seen in? Here's a caustic neuroma. That is hyperesthesia of the part that is supplied by the facial in the external acoustic meatus. Bryce sign, what is that? That is in laryngocele. When we compress the swelling, because of sudden gush of air into the larynx, there's a hissing sound. So here the answer is Schwartz sign. A patient underwent surgery for nasal obstruction, now presents with crusting. Endoscopic picture is given, which surgery was done. Okay, so what we can see here is a perforation of the nasal septum. So which surgery can lead to a perforation of the nasal septum? Yes, septal surgeries can lead to perforation of the nasal septum. We know that, right? Out of which the septal surgeries, what do we know? We know of the septoplasty, we know of SMR, submucosal resection. And if we talk about the complications are more in septoplasty or in SMR. Yes, in SMR. So now let us see what are the choices that are given. SMR, can SMR lead to perforation of the septum? Yes, we know that in SMR, except for a S-shaped strut of septal cartilage, we remove everything. So here, in all this area, we have just the mucosal lining of both the sides, no septum in between. So yes, there are chances of perforation, there are chances of saddling because the support of the dorsum is gone. So yes, this can lead to, let us see the other choices first. Inferior meatal antrostomy. What is this? Have you heard of it? Even if you've not heard of it, what do you understand by the name? Inferior meatal antrostomy. So yes, it is making an opening in the inferior meatus. Inferior meatus means where? On the lateral wall. So in the inferior meatus, we are making an opening, that is inferior meatal antrostomy. Where do we do that? Yes, we have seen that. Where we do that? Yes, whenever we go for cadval lap, we give a sublabial incision and we approach the maxillary sinus by making an opening on the anterior wall of the maxillary sinus. Now, after doing the surgery, we pack this maxillary sinus by a pack and then we stitch the sublabial incision. So, following the surgery in the post-operative period, how are we supposed to remove that pack? Should we again give the incision to remove the pack? No. So, what we do then is we make an opening in the inferior meatus through which we pull out the part of the pack, an end of the pack. So the pack removal will be done through this opening, and this will also act as a site of drainage of the blood collection or the collection whatever is collected post-operatively. So that is inferior meatal antrostomy. That is done in the lateral wall, not on the septum. FES, what is FES? Functional endoscopic sinus surgery. Sinuses open in the lateral wall, and to approach the sinuses, we approach them through the lateral wall, not through the septum. So no, FES will also not lead to a perforation on the septum. Denker's operation. Now, what is Denker's operation? Yes, this is not a very commonly done operation. It is a surgery that is done for the maxillary carcinomas. It is, yes, see here. What we do here is we remove the lateral wall of the nose, that's the medial wall of the maxilla, and the anterior wall of the maxillary sinus to approach the maxillary sinus to remove the tumor from there. So it is a type of maxillectomy that we are doing, Denker's operation. So again, it is not dealing with the septum. So what is the answer here? Yes, it is SMR. So even if you do not know what is Denker's operation, you know what is SMR, right? And we know that the chances of complication are high in SMR. So the answer here is SMR. So the next question, a nasal surgery was done in this patient and the incision mark is shown. Which of these was probably done? So we can see that a nasal surgery has been done in this patient is what is given in the question. We can see the mark is like this on the cordula of the nose. So in this surgery, will we give this incision? Okay, so even if we have not seen this incision earlier, let us see whether we can come to the diagnosis or not. So the first choice is cadval lap. We know how is cadval lap done? Yes, we give a sublabial incision, we open the maxillary antrum through the anterior wall. Nothing is done to the nose. No incision is given on the external nose, right? So it cannot be cadval lap. Midfacial degloving. We have also seen that midfacial degloving is an approach, yes, to the maxillary sinus or to remove the angiofibroma. And here we give a sublabial incision from one molar to the other and we raise the skin flap and we give this incision so that we avoid giving any external incision and any external scar. So here also, this is an incision on the nose. This is not midfacial degloving. Okay, open rhinoplasty. Can this be open rhinoplasty? What is rhinoplasty? Rhinoplasty we know is a cosmetic surgery which is done to correct the external deformity of the nose. So yes, when we are correcting the external deformity of the nose, the incision can be here lower down. Yes, because it is a cosmetic surgery, we do not want an external incision on the nose. So the incision will be either lower down or it will be inside the nose. So this can be open rhinoplasty. And Denker's, we just saw that is a maxillectomy that we are operating on the lateral wall. So the incision is either sublabial there or we give an endoscopic incision inside the nose that is on the lateral wall to approach the maxillary sinus. So here the answer is yes, open rhinoplasty, right? So even if you have ruled out two choices and you have a doubt between two choices, then you can make an intelligent guess, right? So as was the paper this time, there were many questions where you had to make intelligent guess, which brings us to this point that yes, mugging up, just ratification does not work. We have to have an idea, a concept should be clear so that we can at least to rule out, we can make an intelligent guess, right? So coming to the next question, a patient presents with difficulty in breathing or taking aspirin. Previously, one episode of breathing difficulty had happened on administration of aspirin, which is false about this condition. So here the patient is having difficulty in breathing on taking aspirin. Something like this we have heard. Yes, aspirin hypersensitivity leading to asthma and nasal polyps. What is that? Samples trial. Yes. So here what happens whenever the patient takes aspirin? Is it an allergy to aspirin? No, it is a non-allergic hypersensitivity. It is not IgE mediated. What happens here is the abnormal metabolism of arachidonic acid in some people who are hypersensitive to aspirin. So what happens here is that the aspirin blocks the cyclooxygenase pathway. So the arachidonic acid metabolism gets affected in these patients. So the arachidonic acid, all of it now will get diverted to the lipooxygenase pathway. So this will result in increase in the leukotriene formation. So when the leukotriene formation increases, that leads to bronchoconstriction, that leads to breathlessness, that leads to increase in the mucus production, that leads to the formation of nasal polyps, right? And also, because the cyclooxygenase pathway is blocked, there is decreased prostaglandin, right? So leukotriene is increased, whereas the prostaglandin G2, H2, and E2 is decreased. So these prostaglandins act as mast cell stabilizers. So now the mast cell will get destabilized. It will lead to release of histamine and increase vascular permeability, edema, and that will lead to nasal obstruction. That will lead to the polyp formation, right? So this is how aspirin leads to the Santos triad. Now, can it happen only by aspirin? This aspirin is leading to these things because of blockade of the cyclooxygenase pathway. Yes, the FOX1, it is a FOX1 inhibitor. So any other drug, any other NSAID, which is a FOX1 inhibitor, this patient who is hypersensitive to aspirin will also be hypersensitive to those FOX1 inhibitors, right? So let us see the choices. Aspirin inhibits the cyclooxygenase pathway. Yes. Can happen with other NSAIDs which inhibit COX1. Yes. And also sometimes the NSAIDs which are relatively COX1 inhibitor or relative COX2 inhibitor, they can also lead to this hypersensitivity. It is an allergic response to aspirin and its metabolites. It is not IgE mediated. It is not allergic. It is a non-allergic hypersensitivity. So what is ours is false. So this looks like false. Montelukast is used to inhibit this. Yes, montelukast can reduce, it is a leukotriene inhibitor. So the symptoms that are being caused by the leukotrienes, they can be inhibited or decreased by use of montelukast. So the answer here is C. The next question, gag reflex will be absent in which nerve injury? So what is gag reflex? Yes, very good. It is a protective reflex to protect the entry of unwanted foreign bodies into the airways and into the pharynx. So what happens whenever a very large foreign body or when an unwanted foreign body reaches the oropharynx? Yes, when it touches the base of tongue, the tonsillar area, the posterior pharyngeal wall, the sensory nerve supply of this area senses that this is an unwanted or very large foreign body which can lead to occlusion of the airway, or it can get stuck into the esophagus. So now what happens is that the glossopharyngeal senses that, and it immediately leads to the contraction of the pharyngeal muscles, the constrictor muscles. So the constrictor muscles contract, and that leads to expulsion of this foreign body. This is what is known as gag reflex. So what is the afferent? The afferent is the sensing by the glossopharyngeal nerve, right? And what is the efferent? Yes, the efferent is the contraction of the superior constrictor. That is the motor supply of the pharyngeal muscles, and that is the pharyngeal plexus, the vagus. So the afferent is the ninth and the efferent is the 10th. And if we talk about the pathway, so the 9 sends impulses, yes, to the nucleus of tractus solitarius, from where it goes to the nucleus ambiguous, and the efferent comes through the tympana to the superior constrictor. Again, this is a repeated question. Last year also was the question on gag reflex and how do we test it? Yes, so this is a normal response. But why is it important to us? Because we can test the gag reflex to know whether the ninth and the 10th nerve and all this connection, the brainstem is normal or not. So how do we do that? Yes, we depress the tongue and we touch the posterior pharyngeal wall with the help of a tongue depressor. And what we can see is the contraction of the superior constrictor and also the elevation of the palate. So here the answer is, yes, it is 9 and 10. So the next question, a patient with a history of prolonged intubation presents with breathlessness following a senile laryngoscopy. Staging for this is given by. So again, this is a combination of two questions. First, we are supposed to diagnose what we are seeing here, and then this condition is staged by which staging. So what is this? This is a patient of prolonged intubation. What we are seeing here is the two vocal cords. This is the subglottic area where we are seeing the opening is very small. So yes, this is subglottic stenosis. And so that we have made the diagnosis. So the staging for subglottic stenosis is by, we know it is the Mayer-Cotton classification. The Mayer-Cotton classification stages these subglottic stenosis into 4 grades. The grade 1 being the least obstruction, and here the patient is usually asymptomatic. Here there is only up to 50% obstruction, and as the grades go up, the obstruction goes up with maximum obstruction with no opening at all in grade 4. In one of your exam was asked, patient has 80% obstruction of the airway with subglottic stenosis. So what is the grade? So 80% will be what? Yes, so up to 50% is grade 1, up to 70% is grade 2, and 99% is grade 3. So that was the answer there was grade 3. So here the answer is Mayer-Cotton. AGCC, what is that? Yes, it is the American Joint Committee of Cancer. So this is a cancer staging. And again, TNM is a cancer staging. Frontier is nothing. So the answer is Mayer-Cotton classification. Intraoperatively, which stain is used to view the following lesions? So what we can see here is the vocal cords, right? And on one vocal cord, we can see a very dirty looking like appearance of a growth, right? So intraoperatively, what we can do? Let us see the choices. Supravital, silver nitrate, HNE, Congo-Red. Now, Congo-Red we know is for amyloid. So no. What we are seeing on the vocal cord is a growth. This can be a carcinoma of the larynx, right? So Congo-Red will be amyloid. So no, this cannot be the answer. HNE. HNE is done for the biopsy, or after we have removed this mass, we send it for HNE stain. This is not it will not be done intraoperatively, right? So no. Silver nitrate stain is for proteins. Yes, so no, not this also. So what we are left with is the supravital. So yes, we do use supravital. Supravital is to stain the living cells, usually outside the body, but here we also do it intraoperatively. What we do here is the supravital stain that we use here is the toluidine blue. The toluidine blue, what is done here is that the area is stained with toluidine, it is washed up, and all the area which is carcinoma will pick up the stain, whereas the leukoplakia area will not pick up the stain. So this gives us an idea that which is the area from where we can take the biopsy. Now also nowadays we use methylene blue intraoperatively while we are doing TLM. What is TLM? TLM is transoral laser microsurgery. So in early carcinoma of the larynx, we remove the tumor by laser microsurgery. So here we have to be very, very sure about the margins because we leave very little free margin. So we have to be very sure about the margins. So this staining that area with methylene blue helps us to delineate the margin of the tumor. So what is done there is we stain with methylene blue and then we put a microscope, endoscope, yes, which gives us pictures which are highly magnified, 60 times to 150 times magnification, which helps us to view the cells and the blood supply of that area, blood vessels of that area very nicely, which gives us an idea that this area is malignant and which area is not malignant. That is what is known as contact endoscopy. Contact endoscopy. So the answer here is supravital stain. The given position is, so I am sure you will be doing this in anesthesia, but I am taking this question up specifically because, yes, this question has been asked earlier in ENT also, and this can be asked again later in relation to ENT surgeries. Why? Because this is exactly the position that we use for microlaryngeal surgery. So what is this position? We can see that in this position, there is flexion at the neck, that is flexion at the cervical thoracic joint, and there is extension at the atlanto-occipital joint. So what is this position? This is what is known as exactly like snipping. How we snip? Flexion here at the neck, extension at the atlanto-occipital. So this is known as sniffing the morning air. This is also known as the barking dog position. Yes. And this is used for direct laryngoscopy. This is used for MLS, microlaryngeal surgeries, all the microscopic surgeries of the larynx. Yes, all the laryngeal surgeries, they are done in this position. Why? Because this aligns the axis of the oral cavity with the axis of the larynx and the pharynx. Yes, so it makes our viewing of the larynx very, very easy, right? So this is, let us see the choices. The sniffing position for intubation. Yes, this is the sniffing position for intubation. Bougie insertion. For bougie insertion, we can just insert it in the supine position also. We do not need this position. Neurosurgery. For neurosurgery, yes, we do not need to align the oral cavity and the larynx. So why will this position? No. Position for tonsil removal. Yes, some students said that the last choice here was the neck position for intubation. Neck position for intubation. Neck position for intubation. So this is definitely not only the position of the neck, it is both the position of the neck as well as the head. So it is flexion at the neck, the thorax, neck with the thorax, and there is extension at the atlanto-occipital. But still, some students were not sure what the fourth choice was, so I'll just put it tonsil removal. Why? Because we need to know that this needs to be differentiated from another position, that is the Rose's position. That is again another important question of your exam. There we have extension at both these joints. Extension at the neck also and extension at the atlanto-occipital joint also. Yes, remember it is not hyperextension. It is just extension at both these joints. And how do we do extension at the neck as well as at the atlanto-occipital joint? By placing a bag below the shoulder. So when the bag is placed below the shoulder, that leads to extension of the neck as well as extension of the atlanto-occipital joint. That is Rose's position. And Rose's position is for what? Again, you need to know. It is for, we need this whenever we need the larynx at a higher level. Yes, so that is for tracheostomy. And that is for the adenoidectomy as well as tonsillectomy, when we want the larynx at a higher level and the head at a lower level, so that the aspiration of blood during surgery and following that decreases. So for tracheostomy, for tonsillectomy, as well as for adenoidectomy, right? So this is how we do the microlaryngeal surgery. So maybe a position like this, an intraoperative position is given to you and it is asked, this is done in which position? So this is the boy's position, the sniffing the morning air or the barking dog, or it is also known as Shivler-Jackson. It is also known as Shivler-Jackson position. Why? Because he was the one who discovered that this position will align the oral cavity with the oropharynx, with the larynx and the pharynx. The next question, which of the following statement is true regarding the esophageal foreign body. So it is already given it is a esophageal foreign body. What is this? Yes, this is a coin. We are not seeing any double halo or double ring. So yes, this is a coin. So which of the following statement is true? Let us see the choices. Impaction and perforation cannot cause mediastinitis. Now, impaction of a coin in the esophagus can lead to abrasion, it can lead to stenosis and stricture formation, and rarely it can also lead to perforation, leading to mediastinitis. And perforation following esophagoscopy and removal of the coin is in fact more common, right? So yes, it can lead to, it cannot lead to no. What is also true, right? More commonly seen in adults, so foreign body coin incision is very, very common in children. It is the most common esophageal foreign body in children. In adults, if there is a esophageal foreign body, it is usually a meat bolus, right? Most common site of impaction is at the level of cricopharyngeus. So the impaction can occur, or the esophagus is constricted at 3 levels. We know that, right? The first level is around 15 centimeters from the incisor, central incisor, and that is the upper esophageal sphincter, that is the cricopharyngeus sphincter. The next is around 25 centimeters, and that is at the level of the arch of aorta and the left bronchus, right? It is left bronchus and the arch of aorta. And the third constriction is at around 40 centimeters, and that is where the esophagus enters the diaphragm. That is the lower esophageal sphincter. And out of these, the narrowest part of the esophagus is the cricopharyngeal sphincter. And this is also the most common site of foreign body lodgement. This is the most common site of coin lodgement in the esophagus. So yes, that is true. One of the constrictors of the esophagus is at the level of right bronchus. No, this is at the level of the left bronchus. It is at the level of left bronchus. And earlier also has been a question asked that the most common site of the coin lodgement in the esophagus is, and look at the choices, at or above the cricopharyngeus sphincter, at or below the cricopharyngeus sphincter. Yes, so what will you mark? At or above or at or below? Yes, it will be at or just below. Why? Because if it is above, then the tone of the muscles above the cricopharyngeal sphincter is very high, because their function is to push the food down through the sphincter, right? Whereas the tone of the muscles just below the sphincter is not very high, because they have to relax when the food comes down, right? So if it is that, then what will we mark? At or just below the level of the cricopharyngeal sphincter. So that brings us to the end of the questions that we could recall from the session 1 and session 2 of the NEET-PG 2024. And I hope you could answer them correctly. God bless you.